Here we go. Okay, so we are doing female hormone primer part 2, and we kept this. So when last we left, we just sort of did an overview. We did an overview of the physiology of the menstrual cycle. We talked about a couple of cases: menopausal Marie and cystic Julie. And so now we're going to talk about how to about diagnosis, and then we're going to go into a little bit about treatment. So remember how we do our estrogen-progesterone ratio. We're going to take estrone plus estradiol and divide it by progesterone. Our goal is for that, and we're not concerned with the units here. The numbers fit nicely, so we'll leave them alone. And our goal is for the estrone plus estradiol divided by progesterone to be less than 250. The symptoms of estrogen dominance, which is what will happen, what you'll see with when those numbers are 250 and greater. As you can see, they become more and more severe as the ratios get higher. I've seen ratios in the 7,000 to 9,000. A lot of times you run into it becomes a bit problematic when you'll get a blood level, you'll get a serum level, say estradiol of less than 5. So what do you call that? So I usually call it 0.1 or even 0.01. It's basically just to give us a number that we can work with. You can also do it as just as 0, or and then so when we get a 0, you're going to get a very low number, or when you do the progesterone estrogen ratio, which we'll show you in a minute, you just call it infinity, and then you're just going to assume that you're all the way over on the right hand side. So symptoms of estrogen dominance. So remember, estrogen causes cysts. So ovarian cyst, uterine cyst, which we call fibroids, endometrial cyst, which we call endometriosis, breast cyst, breast tenderness, fibrocystic breast disease, spotting between periods, and gallstones are all symptoms of estrogen excess. Somatic symptoms would be headaches, agitated, irritable, can't sleep, poor libido, headaches, short-tempered. The mood swings and panic attacks. So it's a combination of the symptoms that you see are the cystic issues that you get with estrogen and the lack of progesterone. So that's your estrogen progesterone ratio. We want that to be less than 250. In the olden days, when we first started, when we weren't able to get an estrone, or if an estrone is not available, what we used to do is we used to do the progesterone. And here you need to correct it for the units. Take the progesterone times 1,000 divided by the estradiol. And here our normal ratio is 100 to 500. Anything less than 100 is estrogen dominant. Anything greater than 500 is progesterone dominant. You usually only see progesterone dominance, one, if there's no estrogen and there's a little bit of progesterone. But usually when you're going to see it is when you're treating someone with progesterone and not estrogen for whatever reason. It's pretty rare to see this organically. And so here's menopausal Marie, and just examples of the estrogen progesterone ratio. So you got our estrone is 42. Our estradiol is basically 0. Let's call it 0.1, and your progesterone is 0.1, so it's 42.1 divided by 0.1, and that's your EP ratio is 420. Your PE ratio, remember, it's progesterone, which is 0.1 times 1,000, that's 100, divided by again, this is a 0, so I called it infinity. And so what you're looking at is basically, it's a more progesterone than estrogen. here, but you really can't call it. This is the more important one. I just kind of do this as a look back. So 420 isn't terrible, but again, it's more than 250. And we're going to be in this range here. So you're going to have some mild symptoms. Okay. And you remember Marie also has thyroid issues. So when we talk about, diet things and whatnot, remember that cruciferous vegetables, which we recommend for menopausal patients, are harmful, in at least if they're in the raw form, for the patients with thyroid issues. So we don't treat anybody in isolation, and we're just focusing on this. But we look at all of these other parameters also. Here's Julie, and Julie is terribly estrogen dominant. So the estrone is 274, the estradiol is 191, the progesterone is 0.06. You can do the math yourself. I mean, this is 465 divided by 0.06, and we're going to get 7,750. And she's all the way over here, and she has all these symptoms. Headaches, agitated, irritable, can't sleep, severe mood swings, anxiety, and depression, panic attacks. So it's pretty clear. She also has breast cysts. She has spotting between periods. She has a uterine fibroid. She's pretty much a mess. So, okay, so that should be pretty clear on how to do that. Here's one of the lab slips that we do. We fill in all of the numbers, and you'll notice here, just as an aside, her growth hormone levels are low, her DHEA levels are low, her testosterone levels actually are high, and her, she's estrogen dominant. Prolactin levels we want that to be over 6.0. So but that's sort of less than half of the median. Her vitamin D is quite low. Her thyroid is okay. Just as an aside, I actually had a new patient yesterday. So right when I left Northeast PA, that's when we first started doing vitamin D levels regularly. And in January, February, we would see 6, 8, 10, and that was pretty common. I come out here, it's usually 25 to 35 in the wintertime. I actually had a lady yesterday who was 9. So.
Oh my goodness, you're kidding me.
Yeah. Probably where you are, you never see that.
No, sir.
Yeah, 9. Okay, so one thing that we sometimes will look at is a 28-day saliva test. A lot of the lab companies will do this. I think this one was from Doctor's Data, if I remember correctly. And what you do is you'll get a kit, and it'll have 11 tubes in it, and it'll tell you when to do it. So it'll do it on day 1, day 3, use every other day 5, day 8, and there's 11 samples, and you want to follow the natural progression of your ovulation time here, day 14. Then remember, you get that second bump between days 19 and 21. This is where we like to measure the serum level, because this is where the peak of the progesterone is, and you get the second peak of estradiol here, and that's what those ratios that we're looking for. That's what we're looking for here. So you have to remember that right at ovulation, the progesterone levels are going to be close to 0. Okay, it's going to be quite low. This is a salivary one, so you need to be a little bit careful when you're looking at it to note when the samples were taken. That's on the daily one, because you don't want to have a PE ratio, say, of 700, 800, but it had been having been right on, right at the ovulatory time, because that's actually quite normal. So this is really your peak, the best time to get the samples. Even the saliva samples, this is the best time to get it. So, and then you see down here, and this, they'll even do the progesterone estrogen ratios for you down here. You remember, less than 100 is estrogen dominant. Okay, so they actually do it for you right here. This was another sample, and this was actually Julie here. And as you can see, I mean, she's got this sort of flat line, way high estrogen, and then she's got all this crazy, dipping, and remember, this is where the peak is supposed to be. There's no variation here. So this was sort of a tear down and start all over again. So what we started with is we started with a D&C on her. And then so we scrape the uterine lining, and what that does is it sort of starts the cycle all over again. If you don't want to do a D&C, one way to try to attempt to do it sort of medically is to give the patients progesterone. I usually use 200 milligrams nightly for 5 days, and then take it, or no, sorry, 10 nights, and then take it away. And if the gods are with us, we're going to get a menstrual cycle 5 to 10 days after that. If it doesn't happen, wait 28 days, do it a second time. If it doesn't happen after the second time, by that time, I've already sent them for an ultrasound to see if everything looks normal. Then we're just going to sort of mimic the cycle. If it doesn't look normal, I send them off to the gynecologist. So they need a biopsy. Here are just lab values, that the normal lab values and the different cycles for the saliva tests. That's just for your. Do you guys do saliva tests?
Yeah, we do. Not a lot. It's primarily blood testing, but occasionally we'll do saliva testing.
Yeah. So A4M, don't they tell you, oh, you have to do saliva tests, right?
Yeah. No, actually, Dr. Smith says you have to do saliva testing, and then the next guy that comes and does the lecture after her says, saliva isn't really
well, that yeah. Yeah, I know. So I see not much has changed.
So and then the peacemaker comes, the pharmacologist, Dr. Sawanda.
Yes, yeah.
Yeah. And she says, well, you may have heard that there may be some tension amongst the presenters, but we just want you to be well experienced to know everything. And so she kind of takes the fire out of the fight, I guess.
Right. Yeah. Yeah. Okay. Nothing's changed. Okay. So the estrogen therapy. So we've been through this before. We don't like oral estrogens. You get a lot of the same side effects with oral estradiol that you'll get with the synthetics: higher blood pressures, triglycerides, liver enzymes, sex hormone binding globulin, CRP, so that's your inflammatory marker, carbohydrate cravings, and you'll get decreases in growth hormone, testosterone, and tryptophan metabolism. So what is that? What do all three of those deal with? And also gallstones.
You see all of these with bioidentical oral estradiol as well.
Yeah. Yeah. So this again, and then remember that you have the way higher incidence of 4 to 5 to 6-fold higher incidence of blood clots. So growth hormone, testosterone, and then your tryptophan metabolism. That's all your depression symptoms and chemistry all sort of rolled into one. So patients will come in on estradiol 1 milligram pills, and we really try to get them off of them. There is have we talked about Bijuva?
Yes, the combined
Yeah, it's an
dial.
it's an estradiol progesterone combination. It's an FDA approved drug. They claim and they show studies, and when we do I think when we do estrogen, I actually have their data in the slideshow. They claim that they've reformulated the compounds so that they just didn't take estradiol and progesterone and put them together in one pill, that they reformulated it, and their incidence of blood clots is the same as placebo. So, sometimes you can believe drug companies and sometimes you can't. So I don't know if that's true, that, they'll show you studies, but, they can show you, anything. So I did use it for a while, and we had more patients have problems with it and have to change to something else than with other natural hormones. So, but the ones who can take it, it's more convenient. You got your estrogen and progesterone all wrapped up into one. And some patients did fine with it, but more than the patients, with the either the compounded or even using the patch and then the oral progesterone, the FDA approved versions had way less side effects and discontinuation than with the Bijuva. Okay, the oral estrogens have send the metabolism of estrogen down down to the 4 and 16 hydroxy estrone pathway. So the sort of danger pathways, the toxic pathways, than the transdermals do. So. Okay, so just a quick overview here of what to do with estrogen dominance. We want to add progesterone on nights 14 through 25. If it's not too bad, we can use a cream. If they're pretty severe, if they have severe symptoms, you're going to use a pill. And use the pill form, the oral form. You can go up to 400 milligrams usually for a short period of time. Maybe 1 or 2 cycles, but 100 to 200 milligrams is the usual dose. And those are the commercial products. If you need something in between, then you have to have it compounded. Okay. And from what I remember, because I use mostly the commercial products, I mean, they're much less expensive than having them compounded. They would use an extended release, something E4M they call it. And they'll use lower doses. They'll start at 10 milligrams and I think go to 25, but that's an extended release, and that's a compounded one. So have you ever used those?
No, never. No, sir.
Yeah. Okay. Endocrine disruptors, if you can avoid them, I don't see how anymore, and they're all over the place. Just do the best you can. So use a metal water can, I guess, instead of plastics. So as I'm looking at my Culligan water cooler with the big 5-gallon plastic bottle on top, and the one we have in the waiting room. So anti-inflammatory or paleo diet, keto diet, if that works. The anti-inflammatory foods. Make sure they get some exercise. Green tea extract acts as an aromatase inhibitor. Other ones are quercetin. Quercetin we usually like with nettle, 500 milligrams twice a day. Glycerin or licorice, that works nicely, but you need to be careful with high blood pressure with licorice. Grapeseed extract, resveratrol, which basically comes from grapeseed extracts, and then anastrozole, 1 milligram a day. For 12 weeks, we have used this to reduce fibroids and endometriosis. So we have done that on quite a few occasions, and that seems to work quite nicely. So, and the terrible side effects that the guys talk about, at the men's conferences, to block estrogen. I don't see any of that stuff. I don't know where they get that. They read it in a book somewhere, I guess. It's the bottom of the medication, the package insert, and it said, all these terrible things could happen. I don't. Have you ever seen any really bad side effects from an anastrozole?
No. So yes, actually, I've seen a lot of problems with anastrozole. Yes, sir. Guys, particularly guys who come to Viking who are infected from the performance enhancing drug world, or they read on the forum that anastrozole is the best thing since sliced bread, and they oversuppress their estrogen, and they end up having complete erectile dysfunction and joint pain and severe fatigue, and all sorts of emotional disturbances. Yeah, I see it. I see it a lot.
Don't you get that when the estrogens are high too?
Yeah, well, they do say, that you have similar symptoms with estrogen dominance. I
Right.
gotta tell you, Dr. Clearfield, most of the guys, who have what I've observed, guys who have E2 levels, in the 40s, 50s, and 60s, have the best, symptoms, symptom resolution in all categories of androgen deficiency. Ever since they have, been, a Viking, never, any issues, whatsoever. I had, there's a judge in California that I treat that's one of my patients, and, he walks around with E2 levels in the 90s, and he said, I feel absolutely amazing. Do I need to change anything? And we went through the whole discussion about about the estrogen dominance, higher levels of E2, and he said, well, I really don't want to change anything. I feel fantastic, and my E2 levels have been in the 90s for the past 4 years, and I feel amazing. And I said, oh. So
Yeah. Okay. The AMMG people, the guys get into the 150s. So
yeah.
I don't know. I've always had patients complain about all of those things once we see the estrogens over 40. I get that. I get it. You don't want it at zero. But I think there's got to, still in my mind, there seems to be a happy medium. So maybe you'll be smart enough to convince me that I'm doing it wrong.
No, I really think it comes down to a case by case basis.
Mhm.
What I've seen with estrogen, that males tend to do a little better with, where they feel better, to really in the area of of joint pain and and sexual function, particularly the strength and duration of erections, penile sensitivity, ejaculatory volume. They just do better with higher E2 levels. But I really think it's it just it depends on the expertise of the clinician. You have been doing this far longer than me, Dr. Clearfield, and I know you have amazing
Right.
success with patients.
Well, you can teach an old dog new tricks too. So, yeah, I mean, that's just the scene. When we've had guys in the 60s, 70s, and 80s, and we brought it down to 40, it seems to me they've done better. So I guess the jury's still out on that.
Yes, sir.
Okay. Okay. So the PCOS. Here's a treatment protocol. So low glycemic index diet, and we've gone to gluten-free pretty much for all of these folks now. Mini fast is your sort of intermittent fasting with bone broth. That's what we called it, a while ago. High fat, low carbohydrate diet, low FODMAPs diet, something along those lines. For insulin sensitivity, cinnamon chromium combination. We're actually using berberine and chromium now. There's Zymogen has a combo called Alamax, which is 400 of berberine and chromium. We like that one for that. So that's a combination. For high testosterone, I have to, so metformin and spironolactone are sort of the standards. But I have to let you know that, and you may have heard this also, by the time these patients get to someone like me or even you, that's what they've been given. And I hear it over and over again. If you're going to give me, even when they call to make an appointment, I have polycystic ovaries. If you're going to give me metformin, I'm not even going to bother making an appointment.
Yeah.
Okay, so I don't know what it is about metformin, but I mean, there's a high percentage of these women who just hate it. I don't know what it does to them. But I mean, they're pretty violent against it. So okay, so the saw palmetto, that's half the dose of the male dose for prostate enlargement. By the way, spironolactone works pretty well for the side effects of testosterone, so acne, oily skin, and swelling of the hands and feet. Of course, it's a diuretic. It doesn't seem to block the testosterone effects, the effects that we want, but it does seem to work quite nicely for the side effects. Remember, I don't have it on here. Spearmint tea, a double bag in 1 cup of water. After about, if they use it 5 days a week, on average, they'll decrease their testosterone levels by about up to 20%, which is pretty good. And that's just with Lipton tea, so that's those are some of the remedies that we'll look at. Also, here's Julie again. She's estrogen dominant. So again, caffeine, alcohol, white flour, white sugar, dairy, those are the bad guys. The progesterone we talked about, days 14 through 25 for at least 3 cycles. Either a 5% cream, which is over the counter. I've seen 7.5% over the counter. You don't need a prescription for, or the and again, it's the natural micronized progesterone. I don't think that's an issue anymore. 100 to 200 milligrams. I always tell the patients to look at the bottle when they get it from the pharmacy, because at least here they're allowed to substitute, and every once in a while, usually CVS will try to slip in the medroxy progesterone.
Oh,
So,
wow. Yeah.
So medroxyprogesterone, the doses are 5 to 10 milligrams. So I said, look at the bottle, look at the number. If it's 100, that says whatever we prescribed, 100 or 200, you're okay. If it says 5 milligrams or 10 milligrams, you tell them you don't want it. That's not what we ordered. And if that pharmacist has a problem with it, tell them to call us. So,
yeah, it's funny. I first heard this from from Neo, that said that it's not uncommon. There are some pharmacists who don't understand bioidenticals, and they will just take it upon themselves to substitute it because they think it's the same thing. So it's crazy.
Well, I think it was like during COVID when they were told don't fill ivermectin. Yeah, they were just right. So the nice ones would just say we don't have it. The nasty ones would go report you to the medical board.
I know. It's what a sad story. This I started ivermectin for chemoprophylaxis when I first saw the FLC guidelines, and I take care of sick, critically ill patients in the ICU with COVID who have coughed and spit and vomited on me, and I've never gotten sick, from that. So I really think there's some real good data behind it. So it's just a shame. It's like they see a drug that's been around for almost 100 years, that's cheap, and God forbid we give somebody like that that has almost. I mean, the drug-drug interactions are so minuscule and tolerated by children and adults alike. I mean, God forbid you give them something like that, instead of a, high-priced, expensive antiviral that works 20% of the time.
Well, yeah, I know. I'm going to go into all of that now. All right, 7 keto DHEA. If the estrone is greater than 100, and usually I start getting nervous at 90, 7 keto DHEA will take your estrone and sort of pull it out, send it down to 2-hydroxyestrone pathway the way you want it to go, and it will dissipate it. Dr. Oz, of all people, 15 years ago, used to on his TV show, when he was doing weight loss stuff, would hawk this 7 keto DHEA for weight loss. Well, and that's how it works. It works by decreasing estrone. Estrone, as you know, one of the things it does is it accumulates belly fat. So, okay, DIM is sort of an estrogen, an anti-estrogen alternative. 1 gram a day. Berberine will actually will have a little bit of an effect on estrogen, but more for blood sugar. And then fish oil also is an anti-inflammatory. I'm going to add one on here now that is not on here. So one we've been looking at and seems to be pretty effective is calcium D-glucarate. Have you ever used that?
I have heard about it, when it's been discussed with DIM. In the endocrine module, which I'm halfway through now, Dr. Dr. Smith, mentions it briefly, but not very much. I know that I think they're gonna talk much more about it later on in the module. So
yeah, all right. So calcium D-glucarate, I think it's 25 milligrams is the dose. Will decrease estrogen levels by about 15% within about 6 weeks. It also acts like it acts like butyrate in the GI tract, so it acts as a short chain fatty acid. Okay,
wow.
so it's kind of a twofer.
That's great.
Okay, for C-reactive protein down there at the bottom, we like fish oil and curcumin. For 25-hydroxy vitamin D, you remember how we get our patients up to the midpoint. Remember the goals, 50 to 80 is our range. The midpoint is 65. Normal is 30 to 100. For every 1,000 units, you're going to increase your 25-hydroxy vitamin D level by about 8 points. So Costco's big bottle, 2,000 pills is a 2,000 unit pill. So 2 times 8 is 16. And Julie here is at 17. That would get us to 33. So that would get us to normal, but not optimal. 4,000, you take 2 of them. 4 times 8 is 32. That would get us to 49. 6,000, take 3 of them. 6 times 8 is 48, and 17 is 65. That's pretty much dead center. We use a lot. We use the time released once a week, 50,000 unit vitamin D, and that seems to work pretty well. At 17, she'll probably get us into the high 40s, low 50s. It's not an exact 1-for-1, 8 points for 1 with the time released one, but it works reasonably well. And somebody like Julie here is on a lot of supplements, a lot of medication. So if we can get one once a week, I figure that's usually good enough. At least to start. Homocysteine is a marker for nutrition. It could be a marker for cardiac coronary artery disease. Less than 11 is normal. Our goal is less than 10. If it's over 15, it's a heart issue until you rule out otherwise. So I had a guy show up a couple of weeks ago. It was 41. So we sent him for a stress test that was positive. We sent him over to the cardiologist, and the cardiologist the guy had a 99% LAD lesion. So don't ignore it. Okay.
For elevated homocysteine levels, you mean?
Yeah. Mm-hmm.
Yes, sir.
Yeah, that's part of our routine. IGF-1, I use that as a proxy. I know Dr. Gordon wants to growth hormone and IGF-BP3s with it. But first of all, there's an expense to it. The yield is, unless they're, and I mean, I would get it if you're definitely going to be treating them with growth hormone. You know, you've got to cover yourself. But if you're going to use the secretagogues or the peptides, I think the IGF-1 is probably good enough. Our goal's 200. The secretagogues, you can increase your blood levels there by, usually you can get a 20 to 25% increase in that. The injectables, the Semarelin, the CJCs, probably you can get a little bit more depending on the dose you use. Growth hormone, obviously you're going to get the best results, but again, it's really expensive. There's legal issues with it. It's quote unquote illegal for anti-aging. So I don't know about you. I have enough to deal with. I don't need to bring anything else on my head sort of unnecessarily. So this is a sample of a hormone cream. And this is Dr. Gordon's sample, actually. I actually use higher estradiol levels here. I usually use 0.5 for the starter, so it's biased of 2.5. I did use this. This was his chart, and I found that the estrogen levels really, we got pretty much nowhere. It was almost like giving them nothing until we got the estradiol up to at least 0.5. With breast tenderness, usually I would leave the estrogen out. You kind of don't want to fool around with it. You can use DIM if you think you need some estrogen likes coverage. Also, Relizen, Relizen, is an herbal remedy from a company called Bonafide. It's made from Swedish bee pollen. It's very effective for estrogen low estrogen symptoms. For fatigue, what they're showing you here is that they're lowering the progesterone. Libido, again, I would 2.5 and higher doses of testosterone. Cancer, I wouldn't put the estriol in either. I just leave it out. So, okay. So
Yes,
here's a sample. I mean, there's lots of them. You probably have others that you use, but this is from Dr. Gordon. Here's a way to dose progesterone from saliva, and you know from 328 to 450 all the way up to 1300. You can the progesterone cream. This is a 5% cream over the counter, or actually no, it's a compounded cream. And this is that E4M. That's that extended release. But again, I pretty much just use the commercial doses. The Swedish sunflower oil derivative here, it's made by the same company. This one's called Serenol. Use that twice a day when you're going to dose for progesterone. And again, those are really effective. They used to have a rep, and we used to get samples from them, and then so you can get it from their website, or you can get it on Amazon. I hate sending patients there, but what are you going to do? But I do like their stuff. It works very well, and it works pretty quickly too. So the chasteberry black cohosh combination, they works reasonably well also, to cover the symptoms. And there's lots of combinations. We use Zymogen. One's called Menofem, but there's lots of them. Pretty much every company will have a combo with those in it. So these are the lab values for the 1-day saliva test. And here's a sample treatment plan. Do you do this hormone holiday? What's the latest on that?
You mean on progesterone for females?
Yeah.
Yeah. I typically do not. I know the easiest way to do the holiday is for them to be off of it 1 weekend out of the month. I think, I don't know, it's my opinion, and please correct me if I'm wrong, because I think providers make progesterone replacement just way too complicated. I've only had 1 or 2 patients where they bleed strangely on progesterone, and not on a lot of doses whatsoever, by any means. And so I have to do, some extra work with them, but I will usually give it, Monday through Saturday and have them stay off of it on Sunday.
Hmm.
Uh, and and they end up getting a whole 4 days off of the progesterone a month, and they do just fine. So, um,
Yeah.
one of the things that I know that seems to be real frustrating is that, and we're seeing this a lot at Viking and Dr. Clearfield, is that we are not getting sufficient levels of estradiol when we start postmenopausal women on transcutaneous estradiol. We're just not getting any therapeutic blood levels whatsoever. I mean, the E2 is not moving at all. We could bathe them in that damn cream, and it's not doing anything. I just don't know what's going
Now,
on.
is that like the commercial patches, or is that the compounded stuff, or everything?
It's the compounded cream, and I'm thinking maybe it's just not strong enough. We're not using enough estradiol in the cream. I think maybe that's what's going on. But I don't know. What has been your experience to get safe therapeutic levels? I mean, are you getting it sufficiently with
Yeah.
the?
Yeah. Usually those starter doses I gave you, that those are too low. Usually we need them about 3.0, 3.5. That's probably average. But one of the things I learned, and I'm sure I've told you this, we start low and then build it.
Yeah,
Because if you try to give them full doses right away, they end up having reactions to it, and then they have the side effects. It looks like there's overdose side effects, because the bodies don't like it, especially if they've been down near zero for a long time. So
right.
when they're so we try to sort of layer it, and so we tell the patients, it's going to take us 3 to 6 months to get you up to, where we want to be. If we get it right away, fine, great. But if not, so we started at really a lot lower doses. Those are the ones I showed you. I started a little bit higher. Remember, I told you using estradiol about 0.5, not 0.2. And a lot of times we don't even need to increase it very much, or even at all. So we've been using lower doses, in the last couple of years than we were when we first started out. So,
But what we do notice is that we're, in deference to the lower doses, we're not seeing the estrogen level move at all, but they're getting symptom improvement.
yeah.
So we're not seeing any changes in the biochemistry, but their symptoms are going away. So
Yeah, and usually if I'm okay with that. You know, I don't know how you feel about it, but I'm okay with that. If they're feeling good, I don't like fooling with success.
yeah, no, that's you're right. You're right.
Okay.
Absolutely.
Again, here's a laboratory values. I just kind of give you this as a reference of how much to use with these with saliva values here, and here's progesterone values. I think that's a repeat. And then we're going to talk a little bit about testosterone in women. We have a whole class on that, but let's do a little bit of that. And again, so you already know about Lucy now, right? The elephant in the room.
Yes, sir.
Right? I've told you about Lucy before, right? She was the hotel in Atlantic City, New Jersey, still there. It's now a museum. So usually when I like to talk about this, so remember, there's still no FDA approved testosterones for women. And I like showing this chart, especially to, the white bread medical doctors. When I go to the like NOMA, I talk to them, or the Nevada Family Practice, the ones they don't really know anything about this stuff.
Right.
And I asked them, I asked them, would you ever prescribe anything off label? And usually you're going to get anywhere from a third to half of the crowd will raise their hand and said, we would never prescribe anything off label, right? And so then I show them this. And I said, okay, well, have you ever prescribed SSRIs for hot flashes? To say, that's what the endocrine society says. That's their go-to. That's what they say you're supposed to use first. Or ringing in the ears or tinnitus. And then a couple of hands go down. And then how about amitriptyline for migraines? And then more hands go down. And then how about clonidine for smoking or hot flashes? And then usually by the time I get down to gabapentin for diabetic neuropathy, every hand is down. So they don't even know that they're prescribing off label. So, you know, but they are. So topiramate, this is a little bit old. So, you know, there is that Q-Semen now, which is phentermine and topiramate combination. So I probably should take weight out but by itself, it's not indicated for weight loss. So testosterone does the same thing in women that it does in men. It increases strength, energy, sense of well-being, bone density, bone strength. It restores sexual desire, libido, maintains skin turgor, body composition. It reduces visceral fat, cellulite, wrinkles. It improves depression, anxiety. It's an anti-anxiety agent. It's sense of well-being. It will help improve sense of well-being, muscle tone, urinary incontinence, vaginal dryness. It will reduce LDL cholesterol. By the way, estradiol will increase HDL cholesterol. So if you got somebody who's got really low HDL cholesterol, you can add in a little bit of estradiol. Testosterone deficiency, you should know this, you know, backwards and forwards by now. Again, it's an antidepressant, anti-anxiety agent, chronic fatigue, apathy, bone loss, heart palpitations, urinary incontinence, fibromyalgia, thin skin, vaginal dryness, aches and pains. The effects of testosterone replacement: physiologic testosterone improves leg press strength by almost 50%. It will decrease lean body mass, body fat mass, and and they're all directly associated with serum testosterone levels. And in this study here, you can see testosterone at 1 milligram IM weekly, or daily, 7 milligrams weekly, will decrease weight by 5.4%, abdominal fat, gluteal fat, BMI, after about 8 weeks. Positive effects of testosterone replacement with decreases breast cancer risk by up to 50%, improves dysfunctional uterine bleeding, lichen sclerosis, rheumatoid arthritis, joint pain, bone density, lipid metabolism, and mood. Testosterone and cellulite, you can use combine a cream or a cream with finasteride in the pill form. And remember, the 1.42 to 2.85 milligrams per day is the median to a top amount that a female age 25, that's the peak dose that they will make. So 40 to 90 milligrams a month. You can make a cream with that, with finasteride, and have them do daily leg exercises that to reduce cellulite. You know, there's expensive stuff you can inject now that's, you know, a lot more profitable, but this stuff does seem to work. A daytime glycolic acid, lactic acid cream with testosterone, 1% cream in the daytime, and at night use the ginkgo green tea extract and lipoic acid. Quite frankly, I've never used this stuff, but it's in the literature, so someone's used it at some point or another. This is one of the biggies here. So you get lower risk of breast cancer with testosterone replacement only than you do if we don't treat the patient with hormones at all. And this was per 100,000 women years, and this was done in 2004 in menopause. So, okay, so here's your WHI study of incidence of breast cancer. Here is no hormones at all, and then here's a testosterone only. This is another look at it from a different study. This was from 2013. You get a 2/3 less incidence of breast cancer with patients that are adequately treated with testosterone. So adequately treated with testosterone, total levels 30 to 40, free testosterone about 1 to 3%. Here are the lab values, the median lab values. And then here again, here's the cream. So this is from the saliva test, how to dose from the saliva test. You want to change the site daily when you use a testosterone cream. If you put it on the same spot 4 or 5 days in a row, you're going to end up with little black hairs there. Most of these gals don't like that. But once you take it away, they'll come out. It's not a permanent thing. You can put it on pretty much any area that doesn't have any hair on it. You rub it in. And it says 1 to 2 minutes, which is a long time. It takes 15 to 30 seconds to rub in, but it takes 2 hours to soak in. So you have them put it on and then cover it. You don't want to get it on kids or goldfish or golden retrievers or especially Rottweilers or pit bulls. The dose for the women's dose, if it gets on a male, is probably you're going to get minimal effects, if anything. It may sweeten them up a little bit, but the doses are pretty low for men. And like I said, they can, transfer for up to 2 hours. And notice how I say get on gentlemen callers, lady friends, children, goldfish, and the gardener. So it's. So here again, here's Marie. Here was her testosterone levels. As you can see, they're quite low. They're about half of where we want them to be, and then Julie's are a lot higher than we wanted them to be. So androgen therapy. Now there are some new ones here. There was one testosterone undecanoate orally that was FDA approved, and they say it does not go through the liver, so you don't get the hepatic toxicity. Have you ever used one of that, something like that?
Never, no sir.
Yeah. The problem is it's $800 a month, and there's better options. There's also a nose spray called Natesto. That one you have to use like 3 times a day, and it's also $800 a month. So I don't know how far they're going to get until they get it to be more reasonable. Those are supposed to be the insurance based, I guess. So we do the transdermal, transvaginal. We do that a lot. Transvaginal, especially if they have urinary incontinence, the testosterone will rebuild the muscles around the urethra, and it can improve the urinary incontinence. Usually, it's pretty effective. Probably 80 to 90% of our patients are much better with the transvaginal testosterone. You can also use transvaginal estrogen, estradiol. So, but remember, those stay local. You don't get the systemic effects from that. You can get the pellets, and of course, then remember the DHEA, pregnenolone hormone precursors. Again, to my mind, like I said, I don't use this new one pill out. First of all, I don't trust anybody anymore. That's number one. We'll go with the tried and true stuff that works. That's not that expensive, and we'll stay away from the oral progesterone or testosterones. Most of those are like methyl testosterone anyway. They're synthetics. We had a lady come in the other day. She's on Estratest. You ever see this thing? Estratest.
I've heard of it. I have not seen anybody on it.
No, it's an ethanol. So it's a horse urine based estrogen and a hydroxy testosterone, a synthetic testosterone.
Oh my gosh.
Yeah. So sort of like the worst of both worlds.
And people are still that's still being sold on the market.
Yeah, the lady came in just this week or with us.
Unbelievable. Is it oral or is it transcutaneous?
Yeah, it's oral. It's oral. So there's always hepatotoxicity with the oral testosterones, makes the lipids worse. And then and it really it'll kill the liver, especially I'm sure you're a bodybuilder, you know what happens. These guys, they take all sorts of stuff in their late teens and early 20s, and then by the time they're 40s, they all have liver damage. So that's not you, right?
No sir.
Okay. So transdermal, compounded cream, There are some commercial products. There's a patch. There was a cream called Testum. I don't think that's available anymore. That was a 1% cream. Androgel is really a synthetic. I mean, there's a lot of issues with that. So the doses are usually we start at 0.5 to 1 milligram. I've been limiting it to 2 milligrams unless the patients are usually that's enough, 2 milligrams per day. And usually that's enough. I rarely go higher than that anymore. In the old days we did. The higher you go, you'll get a better effect, but you get more side effects. So you got to balance that. Again, here's that chart with the different doses. You can see the one here that says libido. It gives us a higher dose. And I'll do it. I'll make them in between. I'll make it 1.2 milligram, 2.5, 1.5. Depending on some of it's a bit of a feel. Testosterone cypionate injections. We've not been able to get the 100 milligram, the commercial dose, 100 milligram per cc dose here unless you go to a compounding pharmacy. So I usually do 200 milligrams. 1/10 of a cc is 20 milligrams a week, which is on the higher end of what the female makes naturally. And you can get a 0.05, which is 10 milligrams per week, and you're going to need that, at least that. Okay. Pellets. Do we need to go over those again? I think we've talked about them.
No, sir. No, that's good.
Yeah, we're pretty good on pellets, right? Remember the last 3 to 5 months for females, they use up about 1 milligram per day. So if you do 100 milligram pellet, it should last a little over 3 months on average. 150 milligrams will last 5 months, usually a little bit less, maybe 4 months. You can get infections. You can get pellet extrusions. Usually the patients or do things to it. You put the pellets in and they go out and start riding horses, that afternoon, things like that. So you have to tell them to just sort of take it easy for a couple of days. Occasionally get a bleeding or a bruise. We were doing stitches. If we were getting sutures, we were using 4-0 Vicryl or 5-0 Vicryl. We had a period, and usually 1 or 2 sutures, we'll stop it, stop the bleeding. We had a couple of months here where we couldn't get sutures at all, another shortage. So what I did was I actually got my phone out and I used the timer and I held it for 2 minutes exactly. Using the timer, not counting or estimating it, because I would never get it right, and I was always in a bit of a hurry. Usually 2 minutes is enough. If it's still losing too much, then do it another 2 minutes, and that usually seemed to do the trick. So if you get somebody to stand there for 4 minutes and hold it, usually the kits come with steri strips and the Tegaderm. So you put steri strips on it, put Tegaderm over it. I send them home with a pressure dressing, tell them they can take it off that night, and then they can shower. And most of the time you don't have any problems. So, and again, complications is pretty much using estradiol and testosterone pellets. So you can get a surge, which, especially if their levels are low. So it looks like an estrogen overdose. So what we do is we just double up on the progesterone. Usually 5 to 10 days is enough, or we'll give them a progesterone cream. If they get some breast tenderness, we'll use the progesterone cream on the breasts. And then you can use, the aromatase inhibitors for a short period of time. So the red clover, black cohosh, chaseberry combinations, those work well. Maca root. If you get vaginal bleeding, you want to use, I usually start at 200 for progesterone orally. I've gone up as high as 600, and that usually stops it. If they're still bleeding after a week on 600 milligrams of progesterone, you need to get an ultrasound and look at the endometrial stripe. I had a lady, she was from Central California. She calls me and says she had pellets put in, and she started bleeding. She went back to the place she had the pellets put in, and so they gave her put new pellets in. They gave her estrogen pellets, which of course made it worse. And I had 3 weeks to fix her because she was getting married and moving to Germany. So we were able to do that. She's back now, so we got her on a regular schedule. So okay. This is a dosing schedule. I mean, if you use a Vexapel or BioT, they'll give you a website and they'll give you parameters to put in and give you to give you the doses. But I've used this sort of dosing schedule, and it works fine. And I actually so Jennifer's with the Vexapel, so I told her, here's the dose I would use, and I'm usually within either got it exactly right or I'm 12.5 milligrams off. So I'm pretty close. Okay. And if the doses are too high, you're going to get estrogen dominant symptoms if you're putting estrogen in, or testosterone symptoms if you get put in too much testosterone. So you just do the same things we do for the antidotes. They get oily skin or oily hair, you need to or acne, so we need to do what we do for too much testosterone. So just keep your head about you. And again, the other hormones, pregnenolone is for memory and neuroprotection. DHEA is sort of a mini testosterone. It's an antidepressant. We use the reverse T3 for cortisol. Melatonin resets the daily rhythm. When we dose that, we dose it 2 hours before bedtime. And prolactin levels, when they're low, is an indicative of treatment-resistant anxiety. Again, clinical pearls, estrogen, progesterone offset, weight loss. If the estrone is high, 7-keto DHEA. For high progesterone, to increase progesterone, chasteberry and black cohosh combination, or the Swedish pollen extract, that would be Serenol. And testosterone, we talked about metformin, spironolactone. I usually stay away again from metformin. And if you do use metformin, remember to add in a coenzyme Q10, at least 100 milligrams, in a B complex. Vaginal dryness, you can use either an estrogen cream. There's estradiol commercial products. You can compound an estriol vaginal product, or you can do testosterone vaginal products. Testosterone works much better for vaginal dryness, especially if they have urinary incontinence. And we usually dose it nightly for 2 weeks, then 3 times a week for 2 weeks, and then once or twice a week is necessary. So here are the, we have Marie here, and as you can see, the dates went from February 2017 to May, so just a little over 10 weeks. And you can see the blood levels, and the EP ratio went from 420 to 38. You can see everything's better. Testosterone levels are better. Her vitamin D is better. Homocysteine's better. Hematocrit's up a little bit. C-reactive proteins down by half, 0.5. So you can see everything got a lot better. This is a sleep formula. I don't know if I've showed you this before. Remember, it's got melatonin in it. You want to use it 2 hours before bedtime. So vitamin D, whatever dose you've just prescribed for vitamin D, magnesium taurate, and melatonin, all 3 together 2 hours before bedtime. Okay, for homocysteine, we use the methylated B vitamins. We like methyl SP, and there's a super methyl SP from Apex. I like that one. It's not that expensive, and it's got the betaine in it, and also. So thyroid antibodies, that's the plant sterolins. We talked about those. I think when we did thyroid, we can go over those again. The Moducare and Wobazyme N, they will decrease your thyroid antibody load by 50% in a year. And as long as the patients take them, it's pretty consistent. If we're not getting sort of the results we want, we'll add in some low dose naltrexone, never more than 3.0 milligrams. Use that at all? Low dose naltrexone?
I'm going to start using it.
Yeah, that was one of the lectures in the basic. Remember when we started way back when? So we need to go over that again. We can do that. and an anti-inflammatory C-reactive protein. So omega-3 fatty acids. I usually start at 2,000 milligrams. You can go up to 2,000 twice a day, especially for men. And curcumin, 500 milligrams twice a day, and you can go to 1,000 twice a day. The GI issues, probiotics, prebiotics, and the fermented foods work well. And so here's the cream that we used. These are all the things we used. Urinary incontinence. She was on Detrol LA. 2 weeks after using testosterone, we were able to stop that. Beriberi is a homeopathic remedy that works really well for any type of urinary irritation. We've used this for like 30 years now. It's usually stamped on the bottle for dermatitis, but don't let that deter you. Okay. And these were her doses for thyroid. And I think I showed you this before, right? The endocrinologist called me a shaman and a disgrace to my degree. Right. That was after we fixed her, right? That was after we went from here to here, right?
Have you received any more correspondence from that imbecile?
No, I never even bothered to write him back. Remember, this was the early 2017. It was right in the middle of Trump's they were calling everyone a deplorable, and so I said, this guy just called me a deplorable. No, I don't buy. I got other things to worry about. And further on there was that you see the bottom one there. No, in big letters, legitimate peer-reviewed literature for the use of androgens in women for any reason. Okay, so there you go. So here are my, this was several dozen non-existent peer-reviewed literature for testosterone replacement. Okay, so I think we found did our point. Testosterone in women, 591,000 articles. 2018, just in 2018, over 10,000 articles. Too much testosterone, again, acne, deepening voice, unwanted hair, irregular menses. It will then decrease HDL cholesterol, hypoglycemia, salt and sugar cravings, insulin resistance. So, again, moderation, not too much, not too little. And I think I got to stop here. Okay. So I got to get going.
Sure. Okay.
Okay. So we'll finish this up and then we'll go to, we're doing the female hormone thing, right?
Yes, sir.
Okay. So we'll finish this up and then next time we'll start with estrogen. Okay.
Great. That's awesome.
All right. Let me see if I can see you here. Let's stop the share. There you go. Still a good looking guy. Okay, questions?
So just have one case that I'm dealing with. He is a 60-year-old male in tremendous shape, triathlete, and his tumor marker for his prostate is 7.1. He's had, he is on injectable testosterone from his primary care doctor.
Mhm.
He feels that he would really benefit from testosterone. He's being followed concomitantly by urology. He's had one biopsy that was negative, but his tumor marker continues to evolve, and the urologist wants to do another another biopsy and is absolutely against him being on testosterone. so I was thinking as he was telling me all this, I was thinking, oh my gosh, this is the first time I've seen this guy. Who in Viking put this guy on testosterone? It wasn't us. It was his primary care doctor, and I was like, oh, that's. I didn't want to sound too excited, but he said,
right. So I think you can get it through LabCorp. There's a company that makes something called a 4K score.
Heard about that.
Okay, so the 4K score is supposed to be fairly specific for prostate cancer. Okay. So you may want to look into that. Okay, as far as the PSA, that really the only thing you can do is a total and a free. I don't know what that came out as.
I didn't look at his percent free. That's I'm going to get that here in a subsequent visit. But his main complaint was libido, and erectile dysfunction. So his energy levels are good. Everything else is his athletic performance is great, but he has no libido, and he has unsustainable erection. So from a a functional integrated medicine perspective, anything that you would recommend? He wanted to know about HCG.
Well, local things you can do, trimix if he'll give himself a shot down there. Oxytocin. We use oxytocin nasal spray. PT-141, the peptide.
Yes. So that wouldn't be an issue in the setting of a potential prostate
No,
neoplasia.
they're fine. You're not right. Yeah. Okay.
That's great.
You should be fine with all those. And you and I know that the testosterone should not have any effect on prostate cancer anyway. So we know that, right? We have the literature on that. We've looked at that, ad nauseum. So
his primary care doctor is bold. Basically, I don't care what the urologist says. You're benefiting from testosterone. So that was pretty shocking.
Yeah.
I almost call the guy and say, "Wow, you're the first primary care."
You're the man.
Yeah. So,
right.
All right, sir.
All right. I hate the run, but I got to run. So I'll see you next week. And then the week after that, we'll be partying at the A4M. Okay, we'll be celebrating your graduation.
Yeah, the beginning of my journey. I think that's what it's going to be. That's better said. So,
okay, all right, young man. I will see you next time. Say hello to your lovely bride.
Well, thank you, sir.
Okay.
Bye-bye.
Call me if you need anything.